Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And that is on a very important topic, that is complex febrile seizures beyond the usual clinical spectrum and diagnostic challenges. As we know that this topic is very important topic and we will be knowing it from someone who is expert. So without any further delay, I would like to invite a speaker for this webinar, none other than Professor Dr. Sunil Kumar Agarwala, sir. And let me share some of the achievement of sir. Sir has done MD and Professor at the Department of Pediatrics, Sardar Vallabhbhai Patel, Postgraduate Institute of Pediatrics, Cuttack. So without any further delay, we will be deep knowing about this topic related to doctor's decision making guide for acute febrile seizures management. So without any further delay, I would like to invite sir and hand over this session to sir. Sir, without any further delay, sir, the stage is yours. You can proceed from here.
Okay,
Over to you, sir.
okay. Uh, Good afternoon, everybody. First of all, I thank Faraj from the team of IJCP for disseminating the medical science and knowledge across the country amongst all doctors present in our country. So the topic chosen today is complex febrile seizure beyond the usual clinical spectrum and what are the diagnostic challenges. Everybody, first, I must congratulate the doctors who are logged in and on live to listen this talk. I must say those doctors who are practicing at present, whether they are pediatrician, whether they are clinician, or whether they are any general practitioner, every day you will get one or two cases of febrile seizure in children. At least I can tell that this is the commonest cause of seizure in children. So let me tell you on a questionnaire basis, what does febrile seizure mean? So definition is febrile seizure is fever with seizure, fever with convulsion. Let me tell you what is the difference between seizure and convulsion. Seizure is a broader terminology, but if it is motor in nature and having some motor activity, then we call this as convulsion. And this is very, very pertinent in a particular age group, 6 months to 5 years. And we know that 6 months to 5 year domain is known as febrile seizure without any evidence of neuroinfection. For an example, if a child comes to me at 3 years and having fever in the morning and thereafter a sudden jerk and having fixed gauge, then that is a seizure. And thereafter the child became all right, started vomiting for once and thereafter all right. So this is a case of febrile convulsion. That means prior and post to seizure, no event is there. But contrary to that, if a child is having 1 or 2 days of fever, vomiting, and thereafter unconsciousness and seizure is going on 2 times or 3 times in between since morning, and the child is not regaining consciousness, this will be a case of acute encephalitic syndrome due to neuroinfection. Can it be a bacterial meningitis? Can it be viral encephalitis or scrub encephalopathy? But they are not the cases of febrile convulsion. To say febrile convulsion, the age group is important, 6 months to 5 years. Fever should be there, convulsion should be there, and there should not be any evidence of neuroinfection. So the most common cause of fever is always viral fever. There are other causes of fever. Sometimes you can have vaccine-induced fever. For an example, a child of 6 weeks, a child of 10 weeks, 14 weeks, who is getting combo vaccine, penta or hexavalent, where either whole cell or acellular pertussis component is there, that can trigger fever and relate to seizure. But once it is beyond the domain of 6 months to 5 years, we cannot tell febrile seizure. We have to tell it is fever-triggered seizure. So now febrile seizure, no concurrent CNS infection already I have described. There is no metabolic disturbance like hypocalcemia, hypoglycemia, hypomagnesemia, no history or prior febrile seizures. Then only this will qualify. The range of 6 months to 5 years seizure is known as febrile seizure. So if I put the second question, what are the typical versus atypical and no more used? Now, typical seizure or atypical seizures are obsolete, and that's the reason we are talking of simple versus complex seizure. So what is the difference between simple versus complex seizure, febrile seizure? Any seizure lasting less than 15 minutes is simple. Any seizure lasting more than 15 minutes is complex. If it is more than 30 minutes, it is known as febrile status. It occurs once in a daytime. That means once, if it is more than once, that became a complex. Usually it is generalized any seizure of focal etiology. So that means focal or torus paralysis, that is regarded as complex febrile seizure. no previous neurologic problems, but sometimes patient is a known case of motor delay, cerebral palsy child, or a progressive neurological disease, or a case of inborn error of metabolism. All those conditions, they are associated with complex febrile seizure. So we always tell to certify febrile seizure, the age group 6 months to 5 years is very, very vital, and that has to be maintained. So febrile seizure, what is the incidence? Now I'll tell you the most common cause of seizure in children is febrile convulsion. 2 to 4% of children less than 5 years of age can throw this seizure. Some book writes 1 to 2%. So incidence is as high as 15% in some population, and peak occurrence is around 1.5 years. So that means majority of them, maybe 65 to 90%, they belong to simple febrile seizure. So it has been said that 6 months to 5 years, no evidence of neuroinfection, fever triggered seizure is known as febrile seizure. But beyond that, 6 months below and 5 years after, we can tell them as fever triggered seizure. Out of 100, only 2 kids in between 6 months to 5 years is going to develop febrile seizure. Why? What is the etiology? Now, let me tell you, they are the special group of children who are having genetic mapping, that is SCN1 gene. So that means SC, that means sodium channel 1A and SCN1B gene is involved in them, and they are having experience. I mean, they are more dominating in them, and they are going to present in such a way that positive family history may be there. Sometimes we can get the father or the mother or both of them in their childhood had seizure, and that's why this child is getting inheriting that gene. Particularly, it is autosomal dominant trait, and it is polygenic in nature. No single gene is blamed, but the most common gene, either SCN1A or SCN1B. So it is a genetic disease. That's why out of 100, there are 1 or 2 kids who are genetically susceptible, who are genetically prone, they are going to throw this seizure. Now, what are the common causes of febrile seizure? I have already told it is infection, and most common cause of infection among them is viral. Had it been immunization, yes, even MMR vaccine can throw seizure. That means febrile seizure. Being a fast booster at the age of that also can cause seizure. So that means we always tell that whenever it is there, so that means fever is there, then immunization related fever, that fever can throw seizure. Risk factors, multiple risk factors likely cause febrile seizures. Exposed to smoke, stress in utero, being NICU for more than 28 days, neurodevelopmental delay, first degree relatives with febrile seizure, and family history and genetic disorder. All those things can lead to seizure. So what are the red flags for not febrile seizure? Always I told it is beyond the age group, that means less than 6 months and more than 5 years is not febrile seizure. Seizure with no fever, that is unprovoked seizure, or think of epilepsy, or think of seizure disorder. The long seizure, nowadays working classification is there. Any seizure more than 5 minutes should be thought in the line of status epilepticus. So, but still we follow the book is definition, that is more than 15 minutes is complex, and more than 30 minutes seizure, or in between consciousness is not regained, that is status. Post-ictal persistent weakness, that is Todd's paralysis, is exactly coming into the category of complex febrile seizure. Signs of neuroinfection, meningitis, encephalitis, stub encephalopathy, stiff neck, signs of meningeal irritation, then bulging fontanelle, persistent vomiting. These are red flag signs that they are not febrile seizure. That means you have to go with the alternate diagnosis, neuroinfection. What do we mean by the terminology? Previously known as FS plus, and nowadays they are known as GFS plus. So GE means generalized epilepsy with febrile seizure plus syndrome, or sometimes it is known as genetic epilepsy with febrile seizure plus. So FS plus syndrome is nothing. Either it will start with febrile seizure and along with febrile seizure in the 6 months to 5 year age group. Then it is known as FS plus syndrome. Sometimes you start with febrile seizure, end with febrile seizure, that is also FS plus or GEFS plus syndrome. So the full form of GEFS plus is generalized epilepsy with febrile seizure plus syndrome. What are the febrile seizure related epilepsy syndromes? So now let's discuss genetic epilepsy with febrile seizure plus. Already I told severe myoclonic epilepsy of childhood, very devastating. Few days back, we got a child who had simple febrile seizure, then complex febrile seizure, then multiple seizure, and finally ended with epileptic encephalopathy. And the child did not recover from that. So we have discharged the child with genomic sequencing, and that came out to be SCN1 gene. So it is a case of Dravet syndrome. So Dravet syndrome is known as the most severe form of febrile seizure known to us. In many patients during febrile seizure, if you go for MRI, you can get temporal lobe swelling. And that temporal lobe swelling in the long run may lead to temporal lobe epilepsy or secondary to mesial temporal sclerosis. So it has been told that DNA labs in India, the tests, that means they are going for the genomic testing SCN1A or SCN1B gene to detect, and mere getting that gene in a case of febrile seizure doesn't say that the child will be going to degenerate or not. It is the clinical semiology which is going to decide whether the child is fitting in to Dravet or not. So more severe form is Dravet. So we are going to discuss Dravet syndrome. I mean, Dravet syndrome is the most severe form of febrile seizure associated epilepsy. Onset is in infancy as febrile and afebrile unilateral clonic seizure. Sometimes you can get focal seizure. Seizures recurring every 1 to 2 months. Even they recur every day also. Seizures are typically induced by fever, but they differ from the usual febrile convulsion in that they are more prolonged, are more frequent, are focal, and come in cluster. All those things lead to a epileptic encephalopathy, and thereafter the child may not recover and go for neuroregulation. Usually the child succumb by the age of 5 to 10 years. So that is the most devastating form of Dravet syndrome. So febrile seizures, what are the factors for recurrence of febrile seizure? Now, how will you decide when this child is going to have a recurrence? So there are major criteria and minor criteria. Less than 1 year, the recurrence is high. Duration of fever is less than 24 hours, recurrence is high. Fever, high grade, 38 degree, recurrence is high. Family history of febrile seizure, family history of epilepsy, complex febrile seizure. Daycare people, because many a times we do not know that how to go for intermittent prophylaxis in complex. So recurrence of seizure is high. Sometimes male gender is also going to pose a problem. What are the risk factors for occurrence of subsequent epilepsy? So it has been seen that in a simple febrile seizure, the chance of epilepsy in the long run is very minuscule, that is less than or 1%. Neurodevelopmental abnormality, it can go up to 1/3, 33%. Focal complex febrile seizure, 29%, that is every 1/4, I mean every fourth child can have recurrence or epilepsy. Epilepsy in first degree relative, that is 18%. Fever less than 1 hour before febrile seizure, 11%. Complex febrile seizure of any type, 6%. And recurrence febrile seizure, 4%. So I must tell, don't be panicked. 75% cases in the clinical practice are simple in nature, simple febrile seizure, and there the epilepsy risk is less than 1%. Many doctors, many relatives, many febrile seizure parents, they will ask you, what will happen to the IQ of my child? Because the child has thrown 3 or 4 simple febrile seizure till now. Nothing is going to happen with the cognition or IQ part. Be sure, less than 1%, the child may develop epilepsy, but that type of epilepsy is common, is temporal lobe epilepsy in a child who had febrile seizure in the past. Recurrent after seizure epilepsy. Height of fever is not the risk factor. The seizure, febrile seizure can occur with a low grade fever. It depends on the steep rise of temperature rather than the degree of temperature. That has to be kept in mind. What do we mean by fever triggered seizure? So fever triggered seizure, which is not fitting to the criteria of febrile seizure. Dear delegates, I have already told 6 months to 5 years. This is the age group. Anything beyond say 6 months, that is before 6 months and after 5 years, is known as same entity, is known as fever triggered seizure. So fever triggered seizure, already I told beyond the boundary. So that terminology we are going to use. What do you mean by febrile status? Already I told it is a brand extension of complex febrile seizure. Most common cause of status epilepticus in children is febrile status. The seizure in a febrile seizure child who goes beyond 30 minutes is known as febrile status. 1/3 cases of status epilepticus is febrile. Then there are symptomatic status epilepticus in cases of neuroinfection, and there are the epileptic status epilepticus or idiopathic. They are belonging to the idiopathic seizure category. Seizure duration, as of now, we follow the book recommendation, that is 30 minutes. So classification, simple, already I told, complex, already I told, and febrile status more than 30 minutes. So this duration is very important. And the three category, simple febrile seizure, complex febrile seizure, and last the band extension is febrile status. How are you going to evaluate a febrile seizure child? Now a febrile seizure child, the fever has to be evaluation has to be done. So now this febrile seizure child, the evaluation of the febrile child with a seizure is the same as for any child with fever. Not necessarily each and every child who come to us with a fever of short duration, 1 day or half a day or 1/4 a day, then need not be done any CBC or CRP or blood culture or anything, because they are most commonly are caused by the viruses and respiratory viruses per se, rhinovirus, influenza virus, adenovirus, then comes human metapneumovirus, then comes your coronavirus, COVID virus, all those viruses, even measles, even chickenpox, even hand foot mouth disease, all those viral conditions, they present as fever in a genetically susceptible child, they throw the seizure. So diagnostic evaluation, if there are any suspicion, less than 1.5 year child, if it is a complex febrile seizure or first seizure in a less than 1.5 year child, bulging fontanelle is there, some degree of altered sensorium, some vomiting, then we have to think that the signs and symptoms of meningitis or CNS infection has to be thought of, and how you are going to declare that this child is not having CNS infection, that is by doing lumbar puncture. So it has been shown that many school of thought less than 12-month child, better to go for lumbar puncture. Those who have not immunized against hip and pneumococcal, they may have febrile, they may have neuro infection like meningitis. So that's why they are going to be investigated in the line of ruling out of meningitis. The patient was on antibiotics before convulsion, so definitely we have. If the febrile seizure occurs after the second day of illness, then definitely one has to think of any febrile status, you have to allow meningitis or encephalitis in there. So current recommendation include consideration of a lumbar puncture, especially less than 1.5 year child. Meningeal signs are less important in this age group. So you have to go for first attack of febrile seizure, simple or complex. You have to go for lumbar puncture. What is the role of neuroimaging? This is a very nice question. Neuroimaging and EEG are not indicated routinely after a first episode, a single episode of simple febrile seizure. Even in multiple episodes, we are not going to do EEG. By getting abnormal EEG in a normal child doesn't give an indication to go for long-term anti-seizure medication. So an EEG would not be predict the future occurrence of febrile seizure, epilepsy. Even if EEG is abnormal, neuroimaging and EEG are warranted in complex febrile seizure or with risk factors. For an example, there is history of epilepsy. For an example, it is a neurodevelopmental child. Then we have to go for neuroimaging. So febrile convulsions, how you manage an acute seizure? Let it be of whatever the most important part is, you have to go then and there management in the domiciliary management. Intranasal midazolam has to be given, but in acute seizure management, in a hospital setup, in a hospital care setup, in a clinic setup, we have to go for IV LoRa. Previously, it was IV diazepam. Now we are interested to give little long-acting molecule, that is IV LoRa. So that is most important. If there is no IV access, we can think of IM LoRa or IM midazolam has to be given. But IV phenytoin, IM intramuscular phenytoin is nowhere recommended. At home, no question of IV, because at home IV access is very, very difficult and it will cause more delay, and delay in seizure may lead to complex or status. So that's why it has to be not to be followed. At home, intranasal midazolam is the management. If the child is coming with complex febrile seizure, they should be educated how they are going to manage a seizure if that is going to occur at home. So at home, intranasal midazolam is the answer. So antipyretics, is there any role? So yes, there is a role, because once febrile seizure is there will be panicness of the parents will increase. So in order to comfort the child, in order to comfort the minds of the parents, you have to go for paracetamol. So paracetamol is an antipyretic which will give the comfort to the child. Interfebrile period will be very good if the febrile fever is due to viruses. And recurrent febrile seizure, definitely, but use of antipyretic is not going to decline the probability of recurrence. What are the role of anti-seizure medication in febrile seizure? Yes, anti-seizure medication in febrile seizure in simple, it has no role. But if you are dealing with complex febrile seizure, any pointers, for an example, neurodevelopmental delay, history of family history, and if it is focality in nature, then definitely one can go for long-term anti-seizure medication. Anti-seizure medication of choice, previously it was Phenovar. Now we are not using Phenovar because of its cognitive impairment, but we are happy to give long-term management either by valproic acid or levetiracetam. Nowadays, levetiracetam is having a large window of opportunity, 10 to 60, and we love to give that. In those cases, it is indicated. So that means anti-seizure medications should not be used unless and until it is indicated. Mere getting one or two simple seizure is not an indication to go for. Now, intermittent prophylaxis, simple febrile seizure, there is no role. The American school of thought or Western world, they say no, but in personal experience, evidence-based medicine, let it be simple or complex, we can think of clobazam prophylaxis. So 0.75 mg per kg per day, at least for 1 or 2 to 3 days on initial starting of the fever, can protect or can prohibit the child to go for a seizure. Long-term prophylaxis, yes, I have already told those who are indicated, valproic acid is the answer. What are the outcomes of febrile seizures? There are no long-term adverse effect of having one or more than one simple febrile seizure. Specifically, recurrent simple febrile seizures do not damage the brain. So risk factors of future epilepsy after febrile seizure, already I told, if it is complex febrile seizure, family history of epilepsy, fever duration less than 1 year, developmental abnormality like cerebral palsy, hydrocephalus, or we can say any neuronal malformation, the chances of epilepsy in them is high. So to conclude, intermittent use of antipyretic agents with febrile seizure will give comfort to the baby as well as to the mother. Neuroimaging and EEG are not indicated in simple febrile seizure. Anti-seizure medication should not be used in simple febrile seizure, but they are to be individually case-to-case basis should be discussed to go for anti-seizure medication. At last, to prevent the recurrence of attack in cases of recurrent febrile seizure, particularly simple febrile seizure and complex febrile seizure, we can go for intermittent prophylaxis with oral clobazam, and that is to be given initial 2 to 3 days. And utmost importance is parental counseling. So the gist is that febrile seizure does not have long-term bad effect on brain, do not require regular medication, and does not require any neuroimaging like MRI or SPECT or even EEG, does not alter the normal development of the child. So is it a complex febrile seizure? That has to be kept in mind. Complex febrile seizure are febrile seizure which are complex. They may occur more than once in an illness. A focality of the seizure of more than 15 minutes, 15 minutes may need investigation to rule out the epilepsy, which is underlying, which is provoked by the fever. And these are the conditions where long-term anti-seizure medications by valproic acid or levetiracetam can be thought of. So, dear delegates or dear participants, dear doctors, I thank all of you for a present hearing. A long way to go, and febrile seizure is very common. It has been shown that the most common emergency from the neurology chapter of pediatrics, it is none other than a febrile seizure. And knowing little bit of febrile seizure, thinking that how to rationalize the practice of febrile seizure will give definitely a boost to you in your day-to-day management. So thank you very much. Now over to Faraj. If there are any questions, I will clarify those questions. Over to Faraj, and thanks, a big thanks to the IJCP team. Thank you.
Thank you so much, sir, for taking out your important time and sharing the important knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
Yes. Please go ahead.
First question is, sir, in well-appearing, fully immunized 18-month child presenting with a simple febrile seizure, generalized duration, less than 15 minutes single event, which diagnosis study is generally considered not routinely indicated according to major pediatric guidelines, sir? Blood
There are,
glucose,
there are
punctual LBC, or complete blood count.
Yes, I'll tell you that if the diagnosis is clinically fitting to the diagnosis of simple febrile seizure and it is a small kid in between the 6 months to 5 years, and it is the duration is 15 minutes and the first attack simple. So the diagnosis is simple febrile seizure. Even somebody has done CBC normal and everything. So there is no indication of going for lumbar puncture. There is no indication of going for MRI or CT scan or any high-end investigation. Only thing clinically it is that, and we are thinking it is a viral fever. So I will tell that please manage conservatively with 2 days of clobazam and along with antipyretic, that is the paracetamol 15 mg per kg per dose 6 hours as long as fever will be there, and give good hydration. The baby should take good amount of water, fruits, juices, so that the she will be or he will be hydrated well. And there is no indication of going any investigation, particularly neuroimaging, and there is no indication for going for long-term anti-seizure medication like valproic acid. That's all.
Uh, Thank you so much, sir, for sharing your expertise, sir. Moving forward, we have another question from Dr. Subramaniam. He's asking, what is the strongest established single risk factor for the long-term development of epilepsy unwoke seizures following an episode of febrile seizures, sir? What's your point of view on that?
The strongest clinical factor, I must tell, it is complex febrile seizure. So what does it mean? It means that in any way it is complex. Either the duration is more than 15 minutes, or it is more than one attack a day, or it is focal seizure, or I can say this is there is a neurodevelopmental disability, and the child is having cognitive delay. And sometimes we are getting autistic children, they are coming with febrile seizure. So they are the factors. So if you ask me what is the strongest clinical factor by which you can think this is away from febrile seizure or it is not the good version of febrile seizure, this is the, I cannot say bad, but the word is complex. And this complex has to be evaluated in point to point or in individual basis so that we can know what led to this type of complexity. Is it the neurodevelopmental delay, or the child is susceptible having a genetic predisposition? That has to be found out so that we can decide whether we are planning for long-term anti-seizure medication or not. So single most important factor to say that it is going towards that is complex febrile. Over to Faraj.
Yes, sir. Thank you so much, sir. Sir, thank you much helpful to Dr. Subramaniam on their daily practice. Moving forward, one last question, sir. Beyond airway, breathing, and circulation, that is ABC, what is the single most critical initial diagnostic step to differentiate being febrile seizure from a serious central nervous system CNS infection in a young infant, sir?
Okay, young infant always the high index of suspicion. If you are asking single most, I will tell in a non-crying child in a sitting posture, if the fontanelle is bulged, that means bulging fontanelle in a less than 1 year child. If a child presented with fever with seizure, I must strongly suspect that it could be neuroinfection meningitis. So that is the answer. And always it has been told, even if it is bulging fontanelle not there, but one has to think of there is neuroinfection in less than 1 year, because the typical meningitis features like bulging fontanelle, like neck stiffness, like cunning sign, all those signs are not evident in that age group. So one suspicion, if the child comes with a complex febrile seizure in a less than one year age group, one has to admit the child, rule out infection is a mandate. Even if simple febrile seizure, it is always better to admit the child, rule out the sepsis screen. If needed, one can go for lumbar puncture and rule out the possibility of neuroinfection meningitis. So that is a mandate, because more than 1.5 year child, we can get neck stiffness, cunning and Brzezinski sign. But in a lesser age group, the finding of this neck stiffness and meningeal signs are less.
Thank you so much, sir, for explaining this question as well with your expertise, sir. I hope, sir, you have done justice to this topic. I can see one feedback from Dr. Subramaniam. Thanks for answering my question, and very important topic. Thanks for covering it. Sir, the feedback, I hope, sir, you have done justice to this topic and able to solve all the queries related to this topic, sir. As there is no more questions, sir, with all your permission, shall we conclude this webinar for today?
Yes, yes. So there are two lines from my side. Number one, I thank Faraj and total IGCP team for disseminating this type of knowledge from one end to the another end of the country. So that is a lovely job. So keep on going, because we are towards the end of the 2025. Who knows, in 2026 more better way we can disseminate in a good way. So all the best
Yes, sir.
wishes for that. And second, those doctors who have logged in and are witnessed this type of program, I thank each one of them, because in spite of their busy schedule, they used to listen unless and until they are in a receptive mood. These type of speeches are useless. So that's why, because they are there, we are able to, and it is a gift to us that we are stimulated that we should disseminate our knowledge to them. So thanks for that.
Yes,
And
sir.
before leaving, through IGCP platform, to all your viewers, I must tell Happy New Year in advance. So thank you very much.
Yes,
Bye
sir.
bye.
Thank you so much, sir. And it was great honor to you also. Like doctors like you are available to share the knowledge for being busy also, like taking time to share the knowledge. That's make us change in the society, sir. And we are great honor, and we would like to see you in future also. And happy New Year to you also, sir. And in future also, we would like to have
Thank you.
different
Thank you.
topics from you.
Thank you.
Till then, take care of
Thank you.
yourself. Take care,
Okay.
sir.
Okay. Okay. Bye bye. Take care.